inviting me to take part in this programme of events. So my name's Lynda Morgan-Jones. I'm the one of the joint leads at Chesterfield, of the Women's Health Service at Chesterfield Royal Hospital. I've actually been qualified as a physio since 1982, so, you know, but I first started my interest in continence and treatment of ladies with incontinence in 1992. So I've been doing this for quite a long time, and even now I'm learning all the time. So because it's an area that is developing still, and I think will continue to develop, thank goodness. Okay, so what I'm going to talk about today is the main types of incontinence, and also around the menopause and why ladies experience an increased risk of developing symptoms around the menopause, and then things that you can do for yourself if you do have any symptoms, and then some signposting to some more resources, and also if you wanted to get some more specialist advice. Okay, so I am really concentrating on conservative management. You know, I'm not going to be talking about any surgical or medicines or for incontinence, but you know, if you did want to ask me some questions on that at the end, if that's a particular interest, then you know, I can answer some questions hopefully. Okay, so the first thing I was going to say was, what do we mean by you know, incontinence? So it's actually defined as an involuntary leakage of urine. So I think the important term there is involuntary. So it's something that occurs accidentally, or it's certainly not planned, and it's something that's, I would say, not wanted, but it's still quite a broad term. So if we look at the most common types of incontinence, so the most common type of incontinence is stress urinary incontinence. And that's defined as the involuntary leakage of urine on effort, or physical exertion or exercise, or on sneezing and coughing. If we look at the symptoms of stress urinary incontinence, ladies tend to complain of leakage of small amounts of urine, so from a few drops to a tablespoon, and it only occurs when there is this stress or increased abdominal pressure that then causes more pressure on the bladder. And if the pelvic floor muscles that support the bladder, and we'll look at that in a moment when we look at the anatomy, if they don't then increase their tone or squeeze around the urethra, the tube that leads from your bladder, then you tend to leak. And then as soon as that pressure is taken off, so say it's when you cough, as soon as you stop coughing, the pressure goes off, and then the leaking stops. So although it's only a few drops, what can happen if you have a persistent cough, or if you go for a run, it can be an accumulation of lots of small episodes, if you like, of incontinence. So some ladies will say, well, I do leak a lot. It's not just a few drops. You know, I can wear a pad and it's absolutely wet through. But it's because it's an accumulation of, as I say, lots of small episodes of incontinence. As I say, it occurs during activities that increase the abdominal pressure. So coughing, sneezing are very common ones, but laughing. We see a lot of ladies when they're pregnant, so also, you know, when they're vomiting or being sick, that's another one. But certain exercises, I put there as an example abdominal exercises, because if you're doing sit-ups, so certain types of abdominal exercise, so if you're doing sit-ups, weight training, so if you're lifting weights, doing kettlebells, that sort of thing, if you're doing squats or lunges, they're the type of thing that will cause you to have episodes of stress incontinence. And then, of course, there's, I say, there's the impact activities such as running, jumping. One of the big ones ladies always sort of report is, you know, that they can't go on the children's trampoline because they're all symptoms of urge urinary incontinence. So I've also sort of put there overactive bladder, because very often these terms are, you know, sorry, it's because I'm menopausal as well, so I get my words mixed up, but they're very interchangeable, these words. But overactive bladder is a group of symptoms. So you get these strong urges, you get frequency, which means that you go to the toilet more often than normal. So it's normal to go to the loo to empty your bladder between 6 and 8 times in 24 hours. So if you're going more frequently than that, then that's classed as frequency. And nocturia, so that means that you're getting up in the night more than once to go to the loo. So OAB, or overactive bladder, you can get urge incontinence with that, or so you can have what's called OAB wet, or you can have OAB dry. So you've got all the other symptoms, you've got the urgency, the frequency and the nocturia, but you actually aren't incontinent. Okay, so as I say, with those types of problem, you're going to get this sudden strong desire to wee that is very difficult to put off, and this can be triggered as well. So I say sometimes it can be if you lay down or sat down and you suddenly stand up, if you go near running water. So sometimes if you go to fill the kettle, you run a bath, or go to the swimming pool, you know, and you get in the pool and then you suddenly got to get out because you feel that you need to go to the loo. And another big one is what we call the key in the lock syndrome. So you're okay, you get home, you put the key in the door, and as soon as you put the key in the door, you get this really strong urge, you know, and you just can't get, you know, inside fast enough to dash to the loo. So they're all symptoms of either urge incontinence if you actually have an accident, or, as I say, overactive bladder. So if we go to the next slide. So this is just some common sort of facts and figures surrounding incontinence. So it's a very common problem. It's a problem that's underdiagnosed, and that's because I think it's something that we don't like to talk about. So there's a big stigma attached to being or having symptoms of incontinence. And I think also it's something that at times in women's lives that they accept that it's something that's normal. So, you know, if someone has to rush to the loo, or they have an accident when they cough and just sneeze, they say, oh yeah, but I'm bound to because I've had a baby, or you know, I'm in the, you know, I'm at the menopause, so, or I'm at that age now. So I think sometimes people accept that it is, normal, so they don't come forward and try to seek help, which is a problem really, because there are things that can be done and it shouldn't be accepted really as something normal and that you have to put up with. So because it is underdiagnosed, it's estimated that there are 7 to 9 million, so that's quite a big difference, a couple of million people in the UK that have incontinence, so about 5 to 10% of the population. But if you asked people if they, just had occasional, incontinence, then, then that can be up to, 45% of the population. It certainly has a negative impact on the quality of life. I've heard someone describe incontinence as not being life-threatening, but being life-changing. And it certainly is, from patients that, I see, they will not go out. Some people, if it's, particularly severe, because they're frightened that they're not going to be able to access a toilet. They might not take part in sport because they know that that's going to precipitate, an incontinence episode. They have to be very careful about what type of clothes that they wear, because a lot of them think that they've got to wear black, or they can't wear trousers, because if they do have an accident, it's going to be visible. So it does have a huge impact on quality of life. We've said that the most common forms are stress and urge incontinence. It affects twice as many women as it does men. So, and when we have a quick look later at the basic anatomy, you'll see, why that is. It can happen at any age, but it is more common as we get older. They say that 1 in 3 women are going to experience, in their lifetime, incontinence. People think that, I think sometimes that it is something that we should accept, and that there's nothing that can be done to improve things, and that's certainly not the case, and it's certainly not the case with both types of the incontinence I've talked about, but certainly with stress urinary incontinence, there's a lot of evidence now showing that pelvic floor muscle training can be very beneficial, and can improve symptoms in 55 up to 76% of patients who have pelvic floor muscle training. Because of the evidence showing that it is, can be successful, then it's now recommended as first-line treatment by in the NICE guidelines. So if we can move on. Lovely, thank you. So if we have a quick look at anatomy, and I say it is a very brief look. I don't want it to become too complicated. So that's the picture that you can see is a lady who's been, chopped down the middle, and you can see that the two white bits on that diagram. So at the front is the pubic bone, so that's the bone at the front of the pelvis, and then at the back you've got the spine, and then at the bottom you've got the coccyx. And you can see that going between those two bones you've got a sling of muscle, and that is your deep pelvic floor muscles. So your pelvic floor muscles, it's not a muscle, it's a group of muscles that run from the pubic bone, as I say, to the coccyx. And the other thing about your pelvic floor muscles is there are two main layers. So there are the superficial layer, so they're the ones that are just underneath the skin, and those muscles don't do anything to stop you from leaking. Okay, so sometimes when you're doing a pelvic floor exercise, you might think, well, yeah, I'm definitely doing it right. I can feel something tightening, but actually you might not be tightening the deep pelvic floor muscles, which they're the ones that you can see on that diagram. And they're the ones that do support the organs, and they're the ones that, as pelvic health physios, we get all excited about, because we're the ones that, they're the muscles that we want you to contract and exercise, because they do, as I say, have an effect on continence, and they also support the organs, so they're very important in preventing prolapse. So the organ at the front there, that little round thing, is the bladder, and then the tube leading from the bladder goes through the pelvic floor muscle. So that's the urethra, and so you can see that if those muscles, because it goes through the urethra, if they squeeze or contract, they can squeeze around the urethra. And so I sometimes say to patients, it's a little bit like squeezing a hose pipe. So if you've got nice strong pelvic floor muscles and you contract them, they can squeeze around that urethra and increase the pressure. And if it's strong enough, and if your urethral pressure is higher than the bladder, or the pressure in the bladder, that you can't leak. Okay. The other thing I think to notice about that diagram is the uterus or the womb, how close that is to the bladder, and then the vagina goes through the pelvic floor muscle. So that's another good reason to have good pelvic floor muscles, so that you can squeeze around there. So that can affect both you and your partner during intercourse, so it can have an effect on that. And then behind that you've got your bowel, lower bowel, and rectum, and again that goes through your pelvic floor muscle. So when we talk about increased risk factors of developing incontinence, when we talk about constipation, you can see why that's going to have an effect, because of where the bowel is and its passage through the deep pelvic floor muscles. Okay, so if we move on, so that's all I want to say about the anatomy. And so I'm just going to talk a little bit about bladder function. So there are two phases of having a wee, if you like, or voiding. So there's the filling or storage phase. So on that diagram you can see like the two little tubes at the top of that bladder, and they're your ureters, and they're tubes that go from your kidneys. So we've got two kidneys. Your blood, when it goes around your body, when it gets to your kidneys, they filter off all the waste out of your blood, and then that doesn't stay in your kidneys, that then travels down the ureters and drips into your bladder. So the bladder is it's a hollow organ that's used that can store urine. So the other important thing about the bladder is the bladder muscle. So you can see like the wall of the bladder is made of a muscle, and during the filling stage that muscle is relaxed. And then as that bladder starts to fill and it starts to stretch, that muscle starts to stretch. Now, it's a very specialized muscle, because normally when you stretch a muscle, what happens is it starts to contract. But the bladder will allow itself, or the muscle will be allowed to stretch for quite a bit before it will start to contract, so it stays relaxed. And during the filling stage, your pelvic floor muscles and the urethral sphincter muscle will help to keep that urethra closed. So there's no leakage of urine. When you empty your bladder, so say the ureters are dripping into the bladder, so it's gradually filling and gradually, starts to stretch, and then it gets to a point where nerves are activated, and they send messages up to the brain to say, I'm getting to the point that I don't really want to stretch anymore, I need to be emptied. And then a message will come back down from the brain, and what happens then is the bladder muscle then starts to contract or squeeze, and the urethral sphincter and your pelvic floor muscle will start to relax, and so then the bladder can empty. So that's what happens normally. So if we go on to the next slide. So this is what sort of, if you like, goes wrong with stress urinary incontinence. So again, in that first bladder, you can see that the pelvic floor muscles are helping to keep that urethra closed tight, and there's no leakage, but there's normal pressure in the abdominal cavity. Then when you cough or sneeze, and that increases the pressure in the abdominal cavity, what should happen then is that there should be, an increase in the tone, so that pelvic floor muscle and your sphincter muscle should start to squeeze a bit more tightly around that urethra. And I say, if that urethral pressure is higher than the pressure in the bladder, you will not leak. So that's good. Now, if there is weakness in the pelvic floor or weakness in the sphincter, then what will happen is it might start to squeeze a little bit, but it's just not strong enough to squeeze tightly enough to increase that pressure sufficiently, and so that's why you leak. Okay, so that's what happens in stress incontinence. Now, with overactive bladder, what happens is if we can, sorry, Alison, if we can go back one more, I should have mentioned this, we can go back to the previous slide. What happens in overactive bladder or urge incontinence, during this filling stage, when that bladder muscle should be relaxed, it starts to contract, it starts to squeeze, so it doesn't allow the bladder to fill to its normal capacity. It starts to squeeze before then, and so as soon as it starts to squeeze, that's when you can get that feeling that you need to have a wee. Yeah, so basically with overactive bladder or urge incontinence, it's a problem with the actual bladder and the bladder muscle, not the pelvic floor muscles. Okay, and just one more thing to say about that, your bladder muscle is what's called a smooth muscle, so it's you can't actively squeeze your bladder or relax your bladder, but your pelvic floor muscles, they're voluntary muscles, so you can squeeze them and relax them, and that's quite important. We'll talk about that later on when you're trying to control these strong urges. Okay, so sorry about that, Alison, if you can move on a couple of slides now. Okay, so this is really just to show that the actual control of this of your continence mechanism is it is very complex. So it involves nerves at different levels. So it involves nerves in the what we call the periphery, so around the bladder. Also spinal nerves and centers in your spinal cord, and then there are areas in the brain as well that are involved, and it's a two-way system. So the bladder is sending messages via your sensory system up to the brain, and then the brain is sending messages down to the bladder and also to the sphincter and the pelvic floor muscles. So because you've got two different sets of nervous system, nerves involved. So you've got your, as I say, voluntary nervous system, and you've got your autonomic nervous system. You've got two different types of muscles. So you've got smooth muscle that are controlled by your autonomic nervous system, and then you've got voluntary muscles that you can squeeze and relax. It's not surprising that things can go wrong. But continence, the other thing I want to say about it is, apart from it being complex, it is a learned skill. So you're not born continent. It's something that you are trained, when you have potty training. But I think that the other thing to say is that if you do lose it as well, it is something that can be retrained as well. Not always, depending on where the damage is, but it is something that can very often be retrained. Okay, so if we can move on again. So what are the common risk factors for developing incontinence? And I put a long list there, and I don't want to go through every single one, but and then they're not in any particular order, although childbirth and certainly a vaginal delivery, and if you have to have an instrumental delivery, so either forceps or Ventouse, more forceps than Ventouse, and if you have a large baby, so we now class a large baby as 4 kilograms and over, so like a 9-pound baby. I can remember sort of years ago it used to be an 8-pound baby, and my baby was only 6 pound 12, and that seemed big enough to me. So if you do have a big baby, if you do have an instrumental delivery, if you have a prolonged delivery as well, so if you're pushing for a long time, they're all things that will increase your risk of developing incontinence, because they're all things that are going to cause trauma and damage to the pelvic floor. But even being pregnant, so the changes in hormones during pregnancy, the strain that is put on those muscles because they have to support that growing baby, and as the uterus gets heavier, that also can cause damage to the muscles and weaken them. So even ladies who have a caesarean section can still have issues with urinary incontinence. Pelvic surgery, because there are a lot of like when we looked at that diagram, nerves in that area, and so you can have damage to the peripheral nerves that supply the bladder, so that can cause problems. And I've put there a hysterectomy because that's probably the most common gynecological surgery that is performed. And looking at the evidence, there didn't seem to be a lot of evidence whether you had an abdominal or via the vagina hysterectomy. You still had this increased risk of developing incontinence, but there is evidence to show that if you have a total hysterectomy, so with a total hysterectomy, the uterus and the cervix, so the neck of the womb and the neck of the womb is removed, you've got an increased risk of developing incontinence. The chronic chest problems, smoking, obesity, the chronic constipation, the repeated lifting, the exercises, they all put increased stresses on that pelvic floor. So that can cause trauma and weakening, so that again is why you're going to then be at an increased risk of developing incontinence. The hereditary is because they've done sort of they've done research with twins, and they've shown that if you've got either a sibling, or sometimes if your mother or had incontinence, you're at a greater risk, and that's probably to do with the type of connective tissue that you've got. So there are different types of connective tissue, and some are a bit more stretchy than others. So that's the hereditary. The medical conditions, if you think of that diagram showing the brain, and I say that the spinal cord. So if you've got a medical condition such as multiple sclerosis, Parkinson's, or you've had a stroke, that's going to affect some of those pathways. So that's why that has an increased risk of developing incontinence. Medications, so there are certain medications. So a very obvious one is a diuretic is going to have an effect on your bladder, but also some antidepressants can increase the risk of developing incontinence, and also some medications that you have for if you've got high blood pressure, they can also affect continence. Before I sort of mention the menopause, because I do want to look at that one in a bit more detail, but age as well. So the natural sort of aging process does affect continence, because from the age of 30 onwards we start to lose muscle fibres and nerve fibres. So your pelvic floor, if you don't exercise it, is going to gradually get weaker as you get older. I've put menopause there in red because I just wanted to talk a little bit more about and highlight some of the changes in menopause that make you more at risk of developing incontinence. So if we can have the next slide, please, Alison. So this diagram. So on the right-hand side, that shows the changes that happen to the vagina and the lining of the vagina post-menopause, when your estrogen levels have really decreased. And then on the left-hand side, you've got, so it's like a before and after, that's before the changes of the menopause. So when you're stop having periods, so and you stop having periods because you are releasing the egg from your ovary each month, your estrogen levels then will start to really fall. And so what happens then is the lining of the vagina becomes a lot thinner. There is less circulation to that area, you produce less secretions. What happens is the tissues become less elastic, they don't stretch as easily, they're drier, and so this can make them more susceptible to like damage. So you can sometimes, after intercourse, get bleeding, or if you have to have an examination and you have a speculum put in, so like when you have a smear test, that can become really uncomfortable. So I say a lot of ladies will be aware of things like vaginal dryness, vaginal burning, or itching, having repeated thrush. Intercourse can become painful. The term used to be called vaginal atrophy or atrophic vaginitis, but because of this similar changes in the urethral tissues, ladies can also experience this burning on your when they have a wee, urgency, frequency. So if you think all those symptoms that I said that we class as overactive bladder, so and nocturia, so getting up, needing to get up in the night frequently to have a wee. Because, as I say, you can get those as well as the vaginal symptoms. In 2014, they changed the terminology, and it's now referred to as genitourinary syndrome of the menopause, or GSM. And so it refers to these multiple changes that occur, not only, as I say, in the vagina, but also in the pelvic floor tissues, in the bladder and the urethra. So this is why you can have an increase in incontinence, because as I say, they're very similar to the OAB symptoms. Sorry. The other thing I put there is that you can have recurrent UTIs, because the other thing that happens is that you get a change in the pH, or the acidity in the vagina and the urethra. And normally you've got a slightly acidic pH in those tissues. And if that goes less alkali, or less acidic, so more alkali, so the pH rises, which, as they can do, what that does is it makes the environment more favourable for what we class as bad bacteria. So you've got good bacteria that will have positive effects on the body, and then you've got bad bacteria or harmful bacteria, and they like it to be more alkali. So when the pH changes in these tissues, they thrive, and that's why you can have an increase in thrush, or one of the reasons why you can get an increase in thrush, or an increase in UTIs round about this time. And of course, if you have UTIs, that then is going to make an increased chance of becoming incontinent. So you have to go to the toilet frequently, and sometimes you don't have get there in time. So that's some of the reasons why, as I say, in the menopause you are more at risk of developing symptoms of incontinence, or you may have mild symptoms before, and then you get to the menopause, and your symptoms become a lot worse, or more noticeable, or more bothersome. So if you can move on, please, Alison. Okay, so what can I do to improve my symptoms, if you do develop these symptoms? And I say, they say 1 in 3 women, or 50%, at some time are going to have, symptoms. So it's not of all the people that are here, sort of listening today, I wouldn't be surprised if, at least half of you have had some symptoms at some time. So are the things that you can do? Absolutely, definitely. So if we can move on to the next slide. So I don't want to spend too long here, because I want to really concentrate on pelvic floor exercises or training. So, but general health advice. So, the losing weight is because, as I say, increased weight puts more stress on your pelvic floor. The stop smoking because of the increased coughing that's associated with smoking, and that's why I've also said seeking advice if you have a chronic cough, because if you can take off those stresses off the pelvic floor, that can sometimes be enough to stop you having incontinence. Now, the staying active is really important, but you know, for those of you who listen to Claire Taylor, you know, when she gave her presentation in December about women in sport, it is so important for you know, doing exercise has such, you know, beneficial effects for our health, but you know, sometimes because there are certain types of exercise that can make you incontinent, it can sometimes be a barrier, but it doesn't have to be, because, as I say, if you get advice about the right type of exercise, then it's, you know, very beneficial, and there is some evidence as well to show that actually walking has, you know, can improve symptoms of incontinence. So, so staying active is really important just for your general health, but it can also, as they be beneficial for your pelvic floor and your if you've got incontinence symptoms. So if we move on to the next slide. So advice, I've said, like for a healthy bladder. So just some, you know, sort of general points. So make sure that you drink enough fluid. And sometimes if you have incontinence, you think, you know, I've had lots of ladies who say, you know, well, if I don't drink, I'll be all right because then I won't need the toilet, or, you know, so I won't leak. You know, that isn't the case, because what happens is if you don't drink enough, so that's why I say aim for 1.5 to 2 litres of fluid, your urine then becomes very strong and concentrated, and then it will irritate the bladder. So then when it, you know, drops in, you know, comes from the ureter and drops into the bladder, because it's strong and concentrated, because your body wants to stay hydrated, so it will, your body will want to preserve, you know, water, so it will, you know, reabsorb that, and your urine then, as I say, becomes more concentrated. If that then irritates the bladder, it makes it contract, and then it gives you the feeling that you want to wee. So, and because it is irritating the bladder, it can be quite a strong contraction, so you get this strong urge. You know, rush to the toilet, and then when you get there, you only do a spoonful, or you only do small amounts. So make sure that you are drinking enough, but also it's the type of drink that you have. So you need to avoid caffeine, because caffeine it will irritate the bladder. You know, it is a stimulant, so you know that's why a lot of people want to have caffeine, because you know it wakes you up, and as I say, it can be a stimulant, and it will stimulate your bladder, and again it will make it contract, and it will make you want to wee. It's also a diuretic, so it makes your kidneys work a bit harder and produce more urine. So you're going to produce more urine, and say your bladder's going to be contracting, so it's going to have a bit of a double whammy effect there if you've got a continence problem. And the same as alcohol. So alcohol is also a diuretic, so you know, just, you know, be aware of that. Other irritants are, you know, citrus drinks can sometimes cause the bladder to contract, and also fizzy drinks. So, you know, just be, you know, aware of that. Avoid drinks just before going to bed. So I tend to say, you know, you don't have drinks sort of a good sort of 2 to 3 hours before going to bed. So that's it. Obviously, if you've got the symptoms of, you know, nocturia, so you are getting up, you know, in the night to go to the loo. But make sure that if you are, you know, sort of limiting your drinks, then make sure that you drink plenty beforehand. Adopt a good bladder routine. So what I mean by that is, you know, don't go just in case. So again, if you do suffer with incontinence and you don't trust your, your ability to control your bladder, you think, oh, there's a toilet there. You haven't really got the urge to go, but you think, well, I'll just go because I don't know when I'm going to see the next toilet. I'm going out. I'm just going to nip to the loo just in case I need to go when I'm out. And the problem is with that is, say, normally what happens is the bladder fills, and it's when it gets, starting to get full, that's when these messages are sent to the brain, and you get that feeling that you want to wee, and that's when you should go. So you should only ever go to the toilet really if you get that urge to go. So as I say, don't go, just in case. And you should be able to, with a normal bladder, go, a good 2 to 3 hours between voiding. So, if you feel that you're going more than 6 to 8 times in 24 hours, you can't sort of go, 3 hours without having a wee, then I would say that you probably haven't got a very good bladder routine, and you ought to get some advice to retrain that bladder, because I say it is a learned skill, so it can be retrained in a lot of instances. Also try to empty your bladder fully, because if you don't empty your bladder fully, then it's going to fill more quickly and you're going to want to go again. Also, if you've got urine, in there, because it's warm, then bacteria have got a nice environment, these bad bacteria, to thrive. So, it can make you more prone to having, urinary tract infections. So I always say to ladies, sit on the toilet, don't hover, because, and if you're worried about, sitting on a dirty toilet seat, you're better off taking some wet wipes and, wiping, and making sure it's clean, and sitting on the toilet, because if you hover, what happens is your deep pelvic floor muscles don't fully relax, and they then can be, holding or squeezing a little bit around the urethra, and so because then that will increase the pressure, it sometimes can stop your bladder from fully emptying. So I say always sit down on the toilet. Always wait for that flow to finish. I know that women are normally very busy, and so you whip to the toilet and then whip off, and particularly we see a lot of postnatal ladies, and when you've got a young baby, or you've got a baby and a toddler, it's you have to quickly rush to the toilet and then rush off again, but wait for that flow to finish. And also, if you do have a problem and you think that you're not fully emptying your bladder, I always tell ladies to alter the position. So just either rock forward and back, even sometimes stand up and sit down, and see if you can do a little bit more. So don't squeeze, don't press on your tummy, don't force down or bear down to empty your bladder, but say just alter your position, because if you have got weakness in your pelvic floor and then you have got a slight prolapse of the bladder, then it just alters the anatomy a little bit, and I say it's a bit like the urethra can get a little bit kinked, and so you alter the position, and then you can do a little bit more. So that's why it's worth just trying that. Okay, and then next slide, please. Thank you. So this is sort of, I suppose, my area of expertise. So it's really important to make sure you've got a good, healthy pelvic floor. If we look at those, remember those risk factors. Aging happens to all of us. So all women are going to age and go through the menopause. So we're all going to have these risk factors. So it is important to do pelvic floor. So it's not something that you should do if you're pregnant or if you've just had a baby. It's something that you, as I say, should do routinely, all women, and certainly I would say on a daily basis. So some of the questions, so if you click again, Alison, please. So these are some of the questions that I get, you know, when, you know, we see patients, you know, how do I do a pelvic floor exercise? You know, how do I know I'm exercising the right muscle, and how often, you know, should I do them? So these are, you know, the most common, I would say, questions I get. So how I teach a pelvic floor contraction is I tell ladies to, when you contract the muscle, because of the shape of the muscle and where it attaches, so it's like a dome shaped, or sorry, group of muscles. But so when that contracts, it's not just a squeeze, it's a squeeze, but it's a lift, and we definitely want it to lift because we want it to come up to the neck of the bladder and support the neck of the bladder. So when you do a pelvic floor contraction, the action that you're looking for is a squeeze and a lift. So a lift up inside, you're going to try to lift that perineum, that area between your, you know, your legs, where, so where you, between your vagina and your back passage, you want that to lift, to you know, come up. So I say, if you've not done exercises before, or you've got symptoms of incontinence, and so that that muscle is obviously weak, then I would do the exercise lying down or possibly in sitting. But lying is the easiest position to start off doing the exercise in, because you've got no gravity. So the minute you either sit up, and certainly when you stand up, gravity's, you know, pulling the organs or down, and so it's already putting some stress on that pelvic floor. So I would start off in lying. Some ladies, why I say, you know, or possibly in sitting, because some ladies actually prefer having, you know, sitting on a hard surface where they've got some pressure on the perineum. And I sometimes say to ladies, if you roll up a towel, so it's like a sausage, and put that sort of high up, you know, at the top of your legs, sometimes you've got then some pressure to move away from when you do your exercise, so it can sometimes help with the lift. And then I tell ladies to squeeze and lift around the back passage, and when I say the back passage, I really do mean, you know, the anus. You know, it's not your big glutes, it's not your big bottom muscles, it is just around the opening. So imagine that you've got wind and you're trying to keep that inside, so you squeeze around, lift around your back passage, hold it, and then squeeze and lift at the front. So imagine that you're having a wee and you're trying to stop that flow. So that's how you sort of do a pelvic floor contraction. But the things that, you know, ladies do wrong when they do the pelvic floor contraction or exercise is that, particularly if it is weak and they really don't know what it's supposed to feel like, they will use all the other muscles in that area. So they will squeeze the legs together. If you're doing it in sitting, you know, you see them do this sort of thing because they're squeezing the big glutes, the bottom muscles. And the other big one is that they draw in or pull in the tummy muscles. So when you do your pelvic floor, don't, or, you know, try not to contract those other muscles. Now, you will feel some tightening in your lower tummy, and that is because your deep tummy muscle and your pelvic floor muscles do work, you know, very closely together. So if you're contracting one, sorry, the other one can come in. So don't worry too much if you feel your tummy tightening, but what you don't want to do is really pull that tummy in to start with. You want to initiate from that pelvic floor, and you really want to isolate it to those muscles, because if you start using your, as I say, your leg muscles, your adductors or your glutes, you're using unneeded energy in those muscles, and if you like, taking it away from the pelvic floor where you want to really concentrate. So how do you know whether you're exercising the right muscle? Now, I say to ladies that what you shouldn't be doing is, you know, when you go to the toilet, you shouldn't be having a wee and then trying to stop it, start it, and do that every time, okay? Because what that does is it encourages you to not to fully empty your bladder. So we don't want you to do that. But what I do say is that it's okay to do that, say, once, every 2 or 3 weeks, to see whether you can do that. So start to have a wee. Don't do it right at the beginning. When that flow is starting to slow down a little bit, just squeeze the pelvic floor, do the contraction like I've just described, and see if you can slow that flow down. Now, you might be able to stop the flow completely, but as long as you can slow it down, then and then sort of try to think what that feels like, because then that shows you that you are contracting your the right pelvic floor, the right muscles. Another way that you can test is if you wear tampons, if you then insert a tampon and then just pull gently on the string and then squeeze that pelvic floor, you should feel it, that resistance if you're using the right muscle, okay? Or if you squeeze and you don't want to pull on the string, you should see that string, if you like, being pulled inwards a little bit, or feel that tampon being pulled in. And then one other thing that you can do, you can use your finger, or although we use a finger when we do examinations, it's probably easier to use your thumb, but you can insert that into the vagina and then try doing a pelvic floor squeeze. And what you should feel is a slight squeeze around the thumb. Sometimes you can feel, if you've got very strong pelvic floor, it being pulled inwards. But if you do try that and you don't feel anything, don't panic, don't worry. But then I would say certainly seek help from either a specialist nurse or a specialist physiotherapist who can sort of do an examination and check that out. The other really big problem that ladies do when they're doing pelvic floor exercises is they hold their breath. And you really don't want to do this, because when you take a nice deep breath in, your diaphragm, so the muscle at the bottom of your lungs, goes down, and so your pelvic floor muscle goes down. So if you take a deep breath in and then hold it, what you're doing is you're fixing your diaphragm, and then that makes it very difficult for this pelvic floor to lift, because it's been, if you like, pushed down. So don't hold your breath. So the best thing to do is to take a nice deep slow breath in, get the air right down into your tummy, and then as you breathe out, then contract your pelvic floor. So get into the habit of, when you're practicing doing pelvic floor, that you do it on expiration, so that when you breathe out, okay? And then what you need to be able to do is to hold that muscle and then breathe in and out while you're still contracting that muscle. So it takes a bit of practice, but you really don't want to get into the habit of taking a breath in and holding your pelvic floor and contracting everything. Okay, so how often you should do them? So it's 3 times. If you look at all the evidence, but the problem is with the evidence is that although the evidence shows that pelvic floor muscle training is effective, they use lots of different exercise regimes, really. So what we tend to sort of say is, 3 times a day if you're trying to retrain that muscle and improve things. So 3 sets a day, and to do some slow squeezes where you squeeze and hold, and then relax. And repeat that, and then some quicker contractions where you squeeze, let go, squeeze, let go. So I tend to, depending on when we're doing an examination, how strong or weak your pelvic floor is and what the endurance is, but doing 10 squeezes of up to a 10-second hold, and then 10 fast squeezes. So, but again, having an examination by either a specialist nurse or a specialist physio will certainly give you a much better idea of, what level you should be exercising at. And that's, as I say, when you're trying to rehabilitate or improve the strength of a muscle. Once you've done that, then just go to a maintenance level. So I tend to say to ladies just once a day, and do some slow ones, some fast ones, and again, the number that you do will vary according to what you expect of your pelvic floor. Just one last thing that I do want to mention is an overactive pelvic floor muscle. So I think a lot of people are aware of weakness in pelvic floor muscles and doing exercises to try to improve the strength or the endurance of the muscle. But you can have overactive pelvic floor muscles. So these are muscles that there's too much tone in those muscles. So they, instead of fully relaxing, that they hold themselves, that there's some tone. Now, if we see this, in a lot of patients. So if you have had, pain, any sort of pelvic pain or low back pain, so any pain in that area, you can get overactive pelvic floor muscles. If you suffer with things like irritable bowel syndrome or constipation, then that can well, it's a bit like chicken and egg, because one can cause one, but equally then if you've got overactive pelvic floor muscles, then you can suffer with constipation. So also, if generally you are stressed, so if you suffer with stress, or you work in a stressful job, or if you do a lot of exercise, so if you are someone who goes to the gym a lot, or does a lot of sport, these are all things that can lead to overactivity in that pelvic floor muscle, so it's not fully relaxing. If it doesn't fully relax, that can then give you symptoms of incontinence or overactive bladder, or even painful bladder syndrome. So it is really important to relax the pelvic floor. So this is why it's important when you do a pelvic floor contraction that you also relax after. How I explain this to patients is it's a bit like if you imagine the pelvic floor like a lift, and when you contract the muscle, you're going up to the top floor. You also want it to come back down to the basement. And sometimes what happens is, because of, say, the pain, or say you're doing a lot of exercise, what can happen is, because your tone is high, it goes up to the top floor, and then it gets stuck at, say, the third floor. It doesn't come all the way back down to the bottom. So and then because it's in this overactive state, then it's going to get tired quite easily, and then when it gets tired, then when you cough and you sneeze and you want it to come in and work, it just doesn't do it, and that's when you're going to have problems in your leak. So if you've been doing pelvic floor exercises, it may be that you haven't been doing them correctly, but and so I say get that checked out. If you've tried pelvic floor exercises and you think they're not working, so make sure that you are doing them correctly. Make sure that you're working them at the right level. But also make sure and be checked out that you haven't got overactive pelvic floor muscles. And then, there are things that we can do to, show you how to decrease the tone. So we just call it down training. So there are, stretchers and breathing techniques that you can do to help to decrease the tone in the pelvic floor. Okay, so I think that's it. I'm not quite sure. If you just move on again, Alison. Yeah, so they're just some useful resources that I've, put up. So some of them will tell you about, pelvic floor and pelvic floor exercises. Some are more to do with continence and the different types of continence. And then I find the menopause doctor one is really good, because actually what I didn't mention is if you do have symptoms of GSM or the genitourinary syndrome of the menopause, one of the things that can be really, really helpful is using a topical estrogen. And I think I didn't listen to Amanda Smith's talk that she did. So if she talked about topical estrogen, so that's an estrogen that you use within the vagina, and because it really you can use, because it works in that area, you can use slightly higher sort of dose or concentrations of estrogen. So although it's a form of HRT, it's not getting into your systemic or your main system, so you're not, you don't have the same problems. But it can be absolutely fantastic if you do have some urinary symptoms or the vaginal symptoms. But the menopause doctor, has got a little section on there where she talks about urinary problems in the menopause and about topical estrogens. And then, so I think that is definitely it. Oh no, I think one more, please, Alison. So just to summarise, incontinence is a very common problem, and particularly in women. It's not something that is inevitable, so you shouldn't, expect that it's something that goes with childbirth or the menopause, or just because you're getting old. So it might happen, but there are things that you can do, either simple things for yourself, and if they don't work, there are evidence-based treatments. So, please seek advice of a specialist. And I put there our service, because you can self-refer to our service or go to the GP because we're not commissioned, I don't think, for every, all areas. So it does depend on your GP whether you can self-refer, but it's worth going on the website and seeing whether you can fill in a form and refer. But if not, as I say, go to your GP. Also in DCHS, you've got the Continence Advisory Service. Although it's a nurse only service, there aren't physios, but the nurses are, excellent. I used to work with them, and they are, all brilliant, and they're very good at doing, an assessment to find out what sort of continence you've got, and also, good treatments. And then